Okay, let's unpack this. Picture the scene. It's, I don't know, 2:00 p.m. on a Tuesday. You're in the clinic, the coffee is definitely wearing off, and you walk into room 3 to see a patient you've seen a dozen times before. But today, something is different.
They usually do look different when the stakes change. There's a look in their eye.
Totally. And the complaint on the surface is familiar. Epigastric pain. That burning, gnawing sensation right in the center of the abdomen, just below the rib cage.
Which, let's be honest, is the absolute bread and butter of gastroenterology. You hear epigastric pain, and your brain immediately creates a short list.
A reflex.
It's a total reflex. You're thinking reflux, you're thinking gastritis, maybe a peptic ulcer if they've been stressed, or taking way too much ibuprofen for a bad knee.
Exactly. It's routine stuff. But then you start taking the history, you dig a little deeper, and the picture, it just starts to shift. This isn't just heartburn after a spicy meal.
The story gets heavier.
It does. They mention weight loss. And not the, oh, I've been hitting the gym and cutting carbs kind of weight loss. We're talking significant unintentional weight loss.
The kind that scares you.
Yeah. The kind where their clothes are hanging off them and their belt is on the last notch. And they're not trying.
And now the alarm bells are ringing. I mean, they're blaring. Unintentional weight loss plus epigastric pain. That is no longer a lifestyle issue.
No.
That starts looking like a malignancy. That is a red flag pairing you just can't ignore.
So you do the workup. You have to. You send them for an endoscopy. You put the camera down the throat into the stomach. And there it is.
Yeah.
You see a mass. A large, undeniable, ugly-looking mass sitting in the stomach wall.
And at that precise moment, clinically, your mind usually snaps to one specific diagnosis, one primary suspect.
100%.
You look at a gastric mass and you think, adenocarcinoma, stomach cancer. The statistics, I mean, they totally back you up. It looks like it, it acts like it, the prognosis is grim, the surgery is massive.
And the conversation you're about to have with this person is going to be one of the hardest you'll ever have.
Absolutely. You're already running the script in your head.
So you take the biopsy, you send it to pathology, and you spend the next 3 days just dreading that follow-up appointment. You're mentally preparing to deliver this awful news, but then the report comes back. And it's a complete plot twist.
It's not what you thought. It's not epithelial cells. It's not a carcinoma.
The biopsy reveals lymphoid cells.
A sea of lymphoid cells.
It's not stomach cancer as we typically know it. It's GI lymphoma.
And that single word lymphoma, it changes everything. It changes the treatment, it changes the prognosis, and frankly, it changes the entire biology of what you are fighting.
It's like you said before we started, it's like preparing for a boxing match and realizing you're actually playing chess.
Exactly. The rules are different, the pieces are different, the strategy is completely different.
Because, as we're going to unpack today, not every gastric mass is an adenocarcinoma.
And crucially, not every ulcer is a malignant carcinoma.
Welcome back to the deep dive. Today, we are decoding the enigma of GI lymphoma. We've pulled together a massive stack of research, case studies, and clinical guidelines to take us all the way from MALT to malignancy.
And this is one of those topics that is, it's notoriously undertaught in medical school, but it is repeatedly tested both on exams and in real life. It's a masterclass in differentiation.
This is not a topic for rote memorization.
Oh, absolutely not. If you just memorize lists, you'll fail this topic. You have to understand the story, the why behind it.
So today we're going to cover why the stomach is this sort of secret hotbed for this disease, the absolutely bizarre connection to a bacteria that might be living in your gut right now.
Which is a wild thought.
And the diagnostic traps that trip up even the most seasoned pros. We have a lot of ground to cover.
We do, and I think we need to start by shifting our geography, our mental map of this disease.
Right. Because when I say lymphoma, your first thought is?
Lymph nodes.
Exactly. We think of swollen glands in the neck, the armpits, the groin. That's the classic presentation, Hodgkin's, non-Hodgkin's. It's a disease at the nodes.
That's the textbook picture.
But today, we aren't talking about nodes. We are talking about the gut.
And that is the first big mental shift for you, the listener. You have to look at the gastrointestinal tract not just as a food processor, but as a lymphoma hub.
A hub, I like that.
It really is. And here's a stat to anchor us. If you look at all the cases of lymphoma that happen outside of the lymph nodes, what we call extranodal sites, the GI tract is the #1 most common location.
Wait, really? Say that again. So if lymphoma is going to show up anywhere other than a lymph node, more than the skin, more than the brain, more than the lungs, The gut is the most likely spot.
Precisely, by a long shot. And if you stop and think about it for a second, it makes perfect biological sense.
Okay, walk me through that. Why the gut?
Well, the gut is the largest immune organ in the body.
Because of the surface area. I know it's massive if you lay it all out.
The surface area is part of it for sure, but it's really about exposure. Think about what you do every single day. You swallow food, bacteria, viruses, environmental toxins. You are constantly introducing foreign antigens into your system.
It's the main interface between the outside world and our inside world.
It's the front line. So the body, in its wisdom, lines the gut with lymphoid tissue. We're talking standing armies of immune cells just waiting, ready to defend the border.
It's like the border patrol of the body, constantly checking IDs.
Exactly what it is. And we have a name for this system. We call it mucosa-associated lymphoid tissue.
And that gives us the acronym ALT-T.
Right, MALT. And here's the fundamental principle of oncology. Wherever you have high cellular activity, where you have cells constantly dividing and reacting to threats,
You have a higher risk of something going wrong.
you have the potential for errors, you have the potential for malignancy. Cancer, at its very core, is often a reputation error, a typo in the genetic code.
Like making a photocopy of a photocopy a million times, eventually it gets distorted.
Perfect analogy. The more replication you have, the more active the immune response is, the higher the chance one of those cells goes rogue.
So it's the price we pay for defense. The very cells that are meant to protect us are the ones that can turn against us if they get, I don't know, confused or overwhelmed.
In a way, yes. It's a system under constant pressure. Now, the GI tract is a long tube. It goes from the esophagus all the way down to the rectum. Are we seeing lymphoma pop up evenly distributed across the whole thing? Is it random?
I'm guessing not. Diseases usually have favorite neighborhoods.
They do. They are creatures of habit. And for GI lymphoma, the epicenter, the undisputed heavyweight champion, is the stomach.
The stomach. The stomach specifically. We're going to get into that, I know. But let's just establish the dominance here first.
The stomach accounts for the vast majority of cases, over half, easily. If you find lymphoma in the GI tract, statistically, you should bet on it being in the stomach. It's the high-yield location.
Okay, so let's zoom in. We're in the stomach. We've got the scope down there. We see those lymphoid cells on the biopsy. Is there just one stomach lymphoma, or are we dealing with a whole spectrum of bad news?
It's a spectrum, but really, for the purpose of high-yield understanding and, for clinical practice, it's a tale of two cancers. You have two major players you need to be able to distinguish because they behave very differently and, crucially, are treated very differently.
Okay, let's meet player one.
Player one is the low-grade, sort of simmering variety. This is the MALT lymphoma we just mentioned. It arises directly from that mucosa-associated lymphoid tissue.
Simmering implies it's slow, indolent.
Yes, indolent is the medical term. It creeps up over years. It's not usually an explosion. It's a slow burn.
Yeah.
It's the kind of thing that might have been developing for a very long time before the patient even notices any symptoms.
Okay, that's LMALT lymphoma. And player two.
Player two is the aggressor, diffuse large B-cell lymphoma, or DLBCL.
That just sounds angrier. The name diffuse large sounds like it's taking up space and not asking for permission.
It behaves angrier. It's a high-grade lymphoma. It grows rapidly. It causes symptoms much faster, and it requires a much, much heavier hand to treat. It doesn't ask for permission. It invades.
But both of these are B-cell lymphomas. They come from the same parents.
Yes, and that is a crucial distinction we'll come back to when we get to the markers. The stomach for lymphoma is B-cell territory. Specifically, these are CD20 positive B-cells.
Okay, CD20 positive. We'll file that away.
But before we get into the heavy chemo and the biology of D-cells, we have to talk more about MALT. Because the story of MALT lymphoma is, in my opinion, one of the most fascinating detective stories in all of oncology.
This was the part of the research that really, it just blew my mind, the aha moment where infectious disease and cancer biology just collide. It really challenges how we think about what causes cancer.
It blurs the lines completely. We are talking about the connection between MALT lymphoma and a very specific bacteria called Helicobacter pylori.
H. pylori, the ulcer bug. This thing is famous.
The very same. H. pylori is incredibly common. It's estimated that half the world's population has it.
Half the world? That's staggering.
It is. Most people are asymptomatic. But it's the primary cause of gastric ulcers and chronic gastritis. But here is the causal link that examiners love and clinicians must not miss. There is an incredibly strong, almost linear association between chronic H. pylori infection and the development of MALT lymphoma.
Okay, walk us through the mechanism here. How does a bacteria cause cancer? I thought cancer was a genetic accident or radiation or smoking. How does a little bug do it?
It is a genetic accident, but think about what provokes the accident, what sets the stage. H. pylori infects the stomach lining. It's an invader. It burrows into the protective mucus layer.
Right, it's setting up camp in a place it shouldn't be.
And your immune system, which is very good at its job, recognizes this intruder. It responds. It recruits lymphocytes, specifically those B cells we mentioned, to the stomach lining to fight the infection.
The turf war.
It's a full-on turf war. The body says, get this bacteria out of here.
Okay, standard operating procedure. That's what the immune system is for. No surprises yet.
Standard procedure. But H. pylori is stubborn. It's uniquely adapted to survive in the intensely acidic environment of the stomach. It has this enzyme, urease, that creates a little cloud of ammonia around it, neutralizing the acid.
It's wearing an acid-proof suit.
It's wearing a custom-made acid-proof suit. So the infection often becomes chronic. It doesn't get cleared. It lasts for years, maybe even decades.
So the war never ends. The immune system is constantly firing, constantly sending in troops, but the enemy just won't die.
Exactly. The B cells are constantly being stimulated. They are being screamed at by their partners, the helper T cells, to divide, activate, fight endlessly, year after year after year.
That's the definition of chronic inflammation.
It's chronic antigenic stimulation. And here is the key to the whole story. If you make a cell divide enough times, eventually it makes a typo. A mutation occurs during replication.
The photocopier finally jams.
It jams. And one of those mutations might, by bad luck, happen in a gene that controls cell growth or cell death. A tumor suppressor gene, for example.
And because these cells are already primed to survive and divide, because the immune system is yelling, go, 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 that one mutated cell now has a huge advantage.
A massive advantage. It starts a clone army. It stops listening to the stop signals. It becomes a neoplasm. And that is malt lymphoma.
That is wild. So the lymphoma is essentially an immune response that went rogue because the bacteria just wouldn't leave.
That's the perfect way to visualize it. It's a cancer born out of a frustrated immune system. It's friendly fire that got out of control.
Which brings us to the exam trap and the diagnostic pivot. If you are presented with a clinical picture, whether it's a patient in your office or a case study on an exam, and you see that triad of H. pylori, a gastric mass, and lymphoid cells,
your brain needs to scream malt. It cannot be a footnote. It has to be the headline. You have to make that connection instantly.
it has to be a reflex.
It does. Because the presence of the bacteria isn't a coincidence. It's the driver. It's the engine on the whole process.
And this isn't just some academic trivia. This understanding fundamentally changes the treatment, which it brings us to section 2, the plot twist.
This is the part that usually shocks medical students. It's a paradox that goes against almost everything we learn about cancer management.
Yeah, usually the algorithm is pretty simple. Cancer equals cut or poison, surgery or chemo. You have a tumor, you get it out of there, or you poison it.
Right, that's the dogma. But with early-stage lymphoma, because we now know it is being driven by the H. pylori stimulation, the first-line treatment is antibiotics.
Treating cancer with a 2-week course of antibiotics, it just sounds like science fiction. Or, frankly, quackery.
Yeah.
Here, take this amoxicillin and clarithromycin for your tumor.
It does. If you told a patient, you have a mass in your stomach that is a type of cancer, but we're going to start with these pills for 2 women and then we'll see, they'd look at you like you were crazy.
I would get a second opinion. I'd think this doctor was, I don't know, a charlatan.
But the data is undeniable. The clinical evidence is overwhelming. For early-stage gastric multi-lymphoma, if you eradicate the H. pylori, if you kill the bacteria, the tumor can actually regress.
Regress? You mean it shrinks?
In a significant number of cases, up to 70 or 80%, it disappears completely. Complete remission.
Just by killing the bug.
Just by killing the bug. Think about the mechanism we just discussed. The tumor is being driven by the constant stimulation from the bacteria. It's like a fire being fed by a steady stream of gasoline from a gas line.
The bacteria is the gasoline.
Exactly. You don't need to bomb the house to put out the fire. You just turn off the gas valve. You remove the stimulus, the H. pylori, and the B cells stop receiving that constant signal to divide. The malignancy loses its drive, and the body's natural processes clean it up.
That is absolutely incredible. It's one of the few instances in all of medicine where we can reliably cure a malignancy by treating an infection. It really makes you wonder how many other cancers are driven by infections we just haven't found yet.
That's a whole other deep dive. But yes, it opens up a massive field of inquiry into the oncomicrobiome. But for this specific disease, it creates a massive clinical pearl. The trap is assuming that mass equals surgery.
Right.
In malt, mass equals check for bacteria, treat the bacteria first.
I can see why this is so high yield. It's completely counterintuitive. Now, surely there's a catch. This can't work 100% of the time. Nature is never that kind.
Of course not. This applies primarily to early-stage malt lymphoma. If the lymphoma has been there for a long, long time, it can acquire additional mutations. It can undergo what we call high-grade transformation.
So it evolves. It stops needing the gas.
Exactly. It becomes H. pylori independent. The cells figure out how to drive their own replication without the external signal. They might pick up a specific translocation, like the T1118 translocation, which activates a pathway called NF-kappa B.
Okay, so it becomes self-sufficient.
It creates its own gas, so to speak. In that case, you treat the bacteria, which you should do anyway, but the tumor stays. It doesn't regress.
So what do you do then? You've given the antibiotics, you've confirmed the bacteria is gone with a breath test or a stool antigen test, you rescope them 6 months later, and the mass is still there. Now what?
Then you escalate. If the lymphoma persists after you've proven the bacteria is gone, or if it was H. pylori negative to begin with, which can happen in a minority of cases, then you move to the next line of treatment.
Which is chemo.
Usually it's radiotherapy first for localized disease. These low-grade lymphomas are incredibly sensitive to radiation. You can often cure it with a relatively low dose of radiation directed just at the stomach.
And you still don't cut it out.
Rarely. Gastrectomy, removing part or all of the stomach, is a morbid surgery.
Morbid meaning risky.
Risky, yes, but also just life-altering. You lose your reservoir for food. You have to eat tiny, frequent meals. You get something called dumping syndrome, where food moves too quickly into the small intestine. You have nutritional deficiencies for the rest of your life.
It changes your relationship with food forever.
Completely. So since these lymphomas are so responsive to radiation and, if needed, chemotherapy like rituximab, surgery has really fallen out of favor as a primary treatment. We try to save the organ if at all possible.
Now let's contrast this with the other player, the aggressive one. DLBCL, diffuse large B-cell lymphoma. Can we give them an unpack and hope for the best?
Absolutely not. That would be malpractice. DLBCL is a different beast entirely. It is, by definition, high-grade and aggressive. It doesn't care about the bacteria anymore.
It's already H. pylori independent from the get-go.
Almost always, yes. It's running on its own internal engine. It has usually acquired multiple genetic hits, like mutations in MYC or BCL2, that make it autonomous and rapidly proliferative.
So if you diagnose DLBCL in the stomach, you're going straight to the heavy artillery.
Systemic chemotherapy, immediately. The standard of care, the regimen that has been proven time and again, is RCHOP.
RCHOP. I always love medical acronyms. They sound so punchy. Break that down for us quickly.
It's a cocktail of drugs. The R is for rituximab, which is a monoclonal antibody, a smart bomb.
The one that targets the CD20 marker we mentioned.
Exactly. It tags the B cells for destruction by the immune system. Then you have the CHOP part, cyclophosphamide, hydroxydonorubicin, which is doxorubicin, oncovin, which is vincristine, and prednisone. It's a combination of classic chemo drugs and a steroid.
So it hits the cells from multiple angles.
Multiple angles to stop division and trigger cell death. But the key takeaway for the listener isn't necessarily memorizing the dosage of vincristine, it's the strategy.
Right. It's the flow chart in your head.
Exactly. Gastric mass with lymphoid cells. Is it low-grade malt? Check for H. pylori. Treat with antibiotics first. Is it high-grade DLBCL? Straight to RCHOP chemotherapy.
And in both cases, neither gets surgery first.
Correct, unless there's a major complication like bleeding you can't control or a perforation. But as a rule of thumb, you don't cut lymphoma out of the stomach as your first move.
Okay, so we've covered the stomach in detail. The B-cell dominance, the H. pylori driver, the antibiotic miracle, that's the stomach chapter. But like we said, the gut is a long tube. Let's move downstream. Section 3, the small bowel.
Shifting geography and, more importantly, shifting biology. We are leaving the acid-filled, churning environment of the stomach and entering the long, winding, nutrient-absorbing world of the small intestine, and specifically, the ileum.
The ileum is the end part of the small bowel, right? The last section before it dumps into the colon.
Correct. And statistically, the ileum is the most common site for small bowel lymphoma. But the risk factors here, the entire story, changes completely. H. pylori doesn't live in the small bowel. It can't survive there. The pH is wrong.
So what's the driver? What's the gasoline in the small bowel if it's not the bacteria?
Here we have to talk about celiac disease.
Celiac.
Okay.
The gluten issue, which I feel like gets a bad rap in pop culture as just a diet fad for some people, but pathologically it's serious business.
It is. It's a serious autoimmune condition. It's a profound, damaging immune reaction to gluten, a protein found in wheat, barley, and rye. And just like H. pylori causes chronic inflammation in the stomach, untreated or refractory celiac disease causes chronic inflammation in the small bowel.
I see the pattern. Chronic inflammation is the common denominator. It's the soil in which these cancers grow.
It always is. It's the unifying theme. In celiac, the immune system is constantly attacking the villi, those little fingers in the intestine that absorb food, every single time gluten is present.
And that leads to all the classic symptoms, right? Malabsorption, diarrhea, weight loss.
Exactly. It's a constant state of immune agitation. The gut is constantly trying to repair itself while simultaneously being attacked by its own immune cells.
But here's the curveball. In the stomach, we were talking about B cells, multi-DLBCL, all B-cell lymphomas.
Right. But in celiac disease, for reasons we don't fully understand, the inflammation primarily drives T cells, specifically a population called intraepithelial T lymphocytes.
So the cancer that results isn't a B-cell lymphoma.
No. It is a T-cell lymphoma. The classic one is called enteropathy-associated T-cell lymphoma, or EATL.
EATL. That sounds scary.
It is scary. It's rare, to be clear, but it is the most feared long-term complication of celiac disease. So if you have a patient who has had celiac for 20 years, maybe they haven't been super strict with their diet, or maybe they have, but their disease is just aggressive, and suddenly they start getting sick again, losing weight, developing pain.
You have to switch your brain from thinking B cell to T cell.
That is the core association you have to burn into your memory. Stomach equals H. pylori equals B cell. Small bowel equals celiac equals T cell.
Are there other risk factors for small bowel lymphoma besides celiac?
Yeah. Other forms of immunosuppression can do it too. HIV is a known risk factor, as are post-transplant patients on immunosuppressive drugs. But celiac disease and ETL is the classic, most tested pairing.
And this T-cell lymphoma, you said it's nasty. It has a very specific and dangerous complication profile. Why is it more dangerous mechanically than the stomach lymphomas?
Think about the anatomy. The stomach is a thick, muscular bag. It's a J-shaped organ designed to churn food and acid. It's tough. The small bowel, on the other hand, is a thin, delicate tube. Its wall is only a few millimeters thick. It's designed for absorption, not for grinding.
So it has less structural integrity.
Far less. When this aggressive T-cell lymphoma infiltrates that thin wall, it weakens it. It eats away at the muscle and connective tissue.
Like a rust spot on a thin pipe.
Exactly. A rust spot that grows. And eventually, with enough pressure from inside, that spot blows out. Perforation.
A hole in the bowel, which is a surgical emergency.
A 5-alarm fire surgical emergency. The contents of the bowel digestive enzymes, billions of bacteria, partially digested food spill into the sterile abdominal cavity. You get fulminant peritonitis, which leads to sepsis, septic shock, and often death, if not treated immediately.
So while we said surgery isn't first line for treating a cancer itself, often these patients end up in surgery because of the complication of the cancer.
Yeah, precisely. They don't present to an oncologist's office with a referral. They present to the ER at 3 a.m. with an acute abdomen. They're screaming in pain. Their abdomen is rigid as a board. You get a CT scan, you see free air in the abdomen, and you take them to the operating room.
And when the surgeon gets in there, they find a perforated mass in the ileum.
And if you know the history of celiac disease, you should immediately suspect EATL. It's a classic presentation.
Is that the only major complication? Perforation?
There's another mechanical issue mentioned in the literature, too. Intussusception.
Yes, a mouthful of a word. Intussusception. I always struggle with that one.
It's a visual diagnosis. It's when the bowel telescopes into itself.
Telescope.
Imagine collapsing a spyglass or an old-school antenna. One segment of the intestine slides inside the adjacent segment, kind of like a sock being pulled into itself.
That sounds incredibly painful and like it would cause a major blockage.
It does both. It causes a complete bowel obstruction, and worse, it drags the blood supply, the mesentery, with it. So it cuts off blood flow to that segment of bowel, leading to ischemia and necrosis.
And the tumor is what initiates this.
The tumor acts as a lead point. It's a solid lump that the normal peristalsis, the squeezing motion of the gut, grabs onto and drags forward, pulling the bowel along with it.
So the exam trap here, or the clinical trap, really.
If you see celiac disease plus a perforated bowel or an obstruction from intussusception, stop thinking about adenocarcinoma of the small bowel, which is very rare. Think T-cell lymphoma.
Okay, so we've differentiated by location, stomach versus bowel, and by cell type, BVST. But let's go back to the beginning, back to that patient in the clinic, the clinical presentation. Section 4, the great mimic.
This is arguably the most high-yield part for the clinician standing at the bedside because before you get the biopsy back, before you send the tissue to the lab, you have to look at the patient, the symptoms, and the images. You have to form a smart differential diagnosis.
And the big rival here, the main contender on that differential, is gastric adenocarcinoma.
Right. They're the two heavyweights in the world of gastric masses. Both cause a mass, both cause pain, both can cause weight loss. So how do we tell them apart at the starting line? We use elimination logic based on their physical characteristics and behavior.
Let's do a side-by-side comparison, a tail of the tape. Let's start with the mass itself on endoscopy.
Yeah.
You're holding the scope, you're looking at the screen in real time. What differentiates them?
Okay. Adenocarcinoma, as we said, arises from the epithelium, the surface lining. It tends to be hard, rigid. It forms what we call an ulcero-infiltrative mass.
Ulcero-infiltrative. It sounds as aggressive as it looks, I assume.
It looks like a crater, a deep, nasty-looking ulcer with heaped-up, angry, irregular edges. And it creates that desmoplastic reaction, that intense scarring. It makes the stomach wall stiff and unyielding.
Like leather.
Exactly. The extreme form is called linitis plastica, a leather bottle stomach. The entire stomach is infiltrated and becomes this shrunken, rigid tube that can't expand at all.
Okay, that's a very clear visual. Rigid, ulcerated like a crater. What about lymphoma?
Lymphoma is different. It arises from the lymphoid tissue under the surface in the submucosa, so it grows differently. It's an inside-out job.
It pushes up from underneath.
It pushes up, so it often causes diffuse thickening of the stomach folds, the rugae.
The rugae, the wavy lines you see in the stomach.
Right. In lymphoma, they get massive. They look swollen, boggy, edematous. Sometimes they describe it as looking like the convolutions of the brain, cerebriform. It's a very different look.
Boggy versus rigid. That's a good tactile distinction. One is soft and swollen, the other is hard and scarred.
And that leads directly to a functional difference. Because lymphoma is softer, more pliable, and lacks that intense scarring reaction, it is surprisingly less likely to cause obstruction.
Even if it's a huge tumor.
Even if it's massive. This is a key clinical point. You can have a lymphoma that fills half the stomach, a huge bulky tumor on a CT scan, but because it's soft, the stomach wall can still stretch around it, food can still push past it.
Whereas a much smaller carcinoma could cause a total blockage.
Exactly. A small ring-like carcinoma can cinch the outlet of the stomach shut because it's rigid. It doesn't give, it shuts the door.
So if you see a patient with a huge mass on a CT scan, but they're still managing to eat reasonably well without vomiting everything up.
That points towards lymphoma. It's a classic discrepancy that should trigger your radar. Huge mass, patent lumen equals lymphoma. Small, tight, obstructing mass equals carcinoma.
Okay, that's a great pearl. What about the symptoms? We mentioned weight loss for both.
Weight loss is nonspecific. Almost every advanced cancer causes weight loss, but lymphoma has the famous B symptoms.
Fever, night sweats, weight loss. But we already have weight loss. So really, fever and night sweats.
Right, and specifically drenching night sweats. And we're not talking about feeling a little warm. We're talking have to get up and change the sheets in your pajamas. Night sweats. Soaked. And cyclical fevers that come and go without any sign of infection. These are systemic inflammatory signs caused by cytokine release-like interleukin-6 from the lymphoma cells themselves. Adenocarcinoma rarely does that.
So if the patient says, "Doc, the weirdest thing is I wake up every night just soaking wet," you lean heavily towards lymphoma.
Heavily! That's a huge clue. And finally, look for the pattern of spread. Adenocarcinoma loves to spread through the lymphatic system early, specifically to the Virchow node.
The left supraclavicular node. The one right above the left collarbone.
Correct. If you feel a hard, rock-like, non-tender nodule there, that's called Toysier's sign, that is overwhelmingly likely to be metastatic carcinoma that has traveled up the thoracic duct from the abdomen. It's less common for primary GI lymphoma to present with just that isolated finding in the same way.
So the not every ulcer rule basically says look closer at the details, the consistency, the function, the systemic symptoms.
Exactly. If the ulcer is clean or if the folds are boggy and thick, pause. Don't just jump to the most common diagnosis, think lymphoma. But ultimately, you can't be sure until you have the biopsy.
Which brings us to section 5, the biological barcode, immunophenotyping.
This is where we get definitive. This is where the detective work at the bedside ends and the hard science in the lab begins. When the pathologist gets those little pieces of tissue, they stain them with specific antibodies to see what protein markers the cells are wearing on their
It's
surface.
like checking their ID badges to see which platoon they belong to.
Exactly. It's cellular identification. And for you, the listener, there are really just two ID badges you need to memorize for this topic to get 90% of the way there.
Just two. I can handle that. I feel like in med school, there are usually 50 different CDs to memorize.
We're keeping it high yield. For the B-cell lymphomas, which are the ones in the stomach, MELLT and DLBCL, the key marker is CD20.
CD20 equals B cell. Simple enough.
If the pathology report says the cells are CD20 positive, you are in B-cell territory. And this isn't just for diagnosis, it's critical for treatment
Because of rituximab.
because of rituximab. Our best drug, our smart bomb, is a guided missile that targets the CD20 protein.
So if you don't have the marker, the drug has nothing to lock onto. It won't work.
Exactly. You would never give rituximab to a T-cell tumor. It would just float right past the cells without doing anything.
Which brings us to the T cell marker. For those celiac cases in the small bowel,
The key marker there is CD3.
CD3 equals T cell.
As simple as that. CD20 for B cells, CD3 for T cells. It's the biological barcode that confirms your diagnosis and guides your therapy.
It's amazing how binary that is. In a world of so many gray areas in medicine, that's a nice black and white answer.
It's the anchor of modern diagnostics. You can argue about what the mass looks like on a scope, you can argue about the patient's symptoms, but you can't argue with the CD marker. That is ground truth.
Okay, we've covered a ton of ground. We've gone from H. pylori to gluten, from antibiotics to chemo, from boggy folds to rigid craters. Let's bring it all together in section 6, the metapattern and rapid recall.
Let's synthesize. If you are listening to this on your commute, or you're preparing for boards, or just trying to look smart on rounds tomorrow, these are the 5 pillars of testing you need to be able to hold on to.
Hit me with the pillars.
Pillar 1, the H. pylori association. It drives multi-lymphoma. It is the gas for the fire. You must check for it.
Pillar 2.
The antibiotic regression concept. MALT is the cancer you can treat and often cure with antibiotics. It is the great exception to the rule.
Pillar 3.
The celiac disease link. Celiac leads to T-cell lymphoma, or EATL, in the small bowel, and you have to watch out for perforation.
Pillar 4.
The markers. The biological barcode. CD20 is B-cell, found in the stomach. CD3 is T-cell, found in the small bowel.
And the final pillar, pillar 5.
The differentiation from carcinoma. Lymphoma is soft, bulky, boggy, and less obstructive. Carcinoma is hard, ulcerated, rigid, and more obstructive. And don't forget the B symptoms and the Virchow node.
I like that. 5 pillars. It simplifies the complexity into a manageable framework. Now let's do a little rapid-fire scenario testing. Put it into practice. I'm going to throw a patient profile at you, and you tell me the high-yield association.
Let's do it. Put me on the spot.
Scenario 1. A 50-year-old male. History of chronic dyspepsia and reflux for years. Endoscopy shows a gastric mass. Biopsy comes back showing lymphoid cells. His H. pylori test is positive.
Diagnosis is MALT lymphoma. First-line treatment is H. pylori eradication therapy. Do not operate, do not start chemo yet. Start the antibiotics, confirm eradication, and then reassess with a follow-up endoscopy in a few months.
Perfect. Scenario 2. A 40-year-old female with a 20-year history of celiac disease. She's been losing weight and suddenly presents to the ER with severe, diffuse abdominal pain and a rigid, guarded abdomen.
That is an acute perforation. The diagnosis is almost certainly enteropathy-associated T-cell lymphoma, EATL. This is a surgical emergency. The immediate next step is the operating room, not the chemo suite.
Scenario 3. A patient has a massive gastric tumor on a CT scan. It takes up a huge portion of the stomach. The radiologist notes diffuse cerebriform thickening of the rugal folds. The patient reports drenching night sweats, but surprisingly, is eating a full diet with no vomiting.
This screams gastric lymphoma, probably a DLBCL given the size and B symptoms. The lack of obstruction, despite the massive size, combined with those B symptoms, points strongly away from adenocarcinoma.
Excellent. Last one, scenario 4. An old patient with significant weight loss, a hard, palpable node just above the left collarbone, and an endoscopy report describing an ulcero-infiltrative mass at the gastric outlet.
That is classic gastric adenocarcinoma until proven otherwise. The hard node is the Virchow node, a sign of metastatic disease. That is the bad one.
You nailed it. It's amazing how the patterns just jump out at you once you know what to look for.
That's the difference between memorizing and understanding. When you understand the underlying pathology, the inflammation, the cell type, the anatomy, The symptoms aren't a random collection of facts. They are the inevitable consequence of the disease process.
And that brings us to the outro. We always like to leave our listeners with a final provocative thought to chew on.
We talked a lot today about H. pylori, and I think it's worth just sitting with the implications of that for a moment. We have a cancer, a full-blown malignancy that is initiated and, for a long time, sustained by a simple bacterial infection.
It challenges the way we categorize diseases. We like to put things in neat boxes. Infectious disease goes in this box. Oncology goes in that box over there.
But the body doesn't have boxes. It's a continuum. Here, the infection is the oncology. It's a direct bridge. And it reminds us that cancer isn't always just bad luck or bad genes. Sometimes it's a reaction, a logical, albeit deadly reaction to an intruder that went on for too long.
And sometimes, the most elegant and effective way to fight the incredible complexity of cancer is to simply remove the intruder, to treat the infection.
It's a humbling reminder of how interconnected all of our systems are. The immune system, just trying to do its job and protect us from a bug, ends up creating a tumor. It's beautiful and terrifying all at the same time.
So, next time you see that gastric mass on a CT scan, or hear that familiar complaint of epigastric pain,
Pause, take a breath, and think about the lymphoid twist.
because not every gastric mass is adenocarcinoma.
And not every ulcer is a malignant carcinoma. Stay curious.
Thanks for diving deep with us. We'll see you on the next one.